Hi, I'm Connie Lee, and this is our very first Angioma Alliance webinar. With us today is Dr. Ed Smith from Boston Children's Hospital. He's going to be talking to us today about the surgical management of CCM. Among his titles at Boston Children's, Dr. Smith is the Director of Pediatric Cerebrovascular Neurosurgery, and he holds the R. Michael Scott Chair in Neurosurgery. Dr. Smith is also the medical director of the CCM Center of Excellence that has been recently recognized by Angioma Alliance. Dr. Smith, welcome.
Thank you very much. It's a real honor to be here, and I look forward to doing my best to talk to you today about management surgically of cerebral cavernous malformations. I will now put some of the slides up here and start off on the talk. So once again, I'm very grateful to be here and be able to share with you today some thoughts on surgical management of cerebral cavernous malformations. I recognize there's a wide range of folks in the audience in terms of folks that are brand new to cavernous malformations and other folks that are experts in it. So I thought I'd sort of start right at the beginning and build up to some of the more interesting issues that are going on. Just by way of introduction, starting from the start, people often ask with cavernous malformations, what are they? Why are they a problem? And in terms of them becoming problematic, what are the treatment issues? If you don't treat them, what is the natural history? What happens to them over time? And if you do decide to treat them, and I'll be talking mostly about surgical treatment today, although there are some very exciting advances in large part supported by the Angioma Alliance, which may not be surgical, but if you do treat them, how do you decide when to treat them? And what are the treatment options available? So that's what I'm hoping to cover a little bit today in this chat. Some of the big challenges, I think, with cerebral cavernous malformations or cavernous malformations in general are how do we innovate, how do we push the field forward so we can better treat families and patients who have these malformations. And some of the biggest questions, I think, at least that I see specifically around surgery are, who do we treat? Some of these things need to be treated, some don't. How do we develop better surgical techniques, being able to be safer and more efficient in our surgery? And lastly, what are some novel treatments? What are some cutting edge advances both in the operating room and hopefully outside the operating room that may make lives better for patients who have cavernous malformations? So to start at the start, what are cavernous malformations? These are blood vessel malformations made up of little tiny bubbles. People always talk about mulberries, and it's funny, I've seen cavernous malformations before I ever saw a mulberry, which is, I guess, unique amongst neurosurgeons. But there's a little picture up here, and you can see this is an MRI picture. There's a big arrow showing this cavernous malformation here, and then this is a picture of a mulberry, and in a surgical picture, you can see how these little bubbles look kind of like the fruit on this berry. Basically, these are little tangles of low flow blood vessels, so not big scary arteries like an aneurysm or another type of malformation called an arterial venous malformation. And these can grow over time. They can kind of fill with blood and inflate and push on things. They can also bleed and leak blood around the outside. They're caused by a lot of different things. Luckily, folks have teased out that in many cases, there are specific genes related to how blood vessels form, somewhat non-innovatively called CCM 1, 2, and 3, which seem to form, at least in genetic and familial cases, these malformations. There are also a number that are caused spontaneously. But ultimately, these tend to grow and cause problems over time in some people, and that's why we're talking about them today. Why are they a problem? Well, in general, they can do two things that are bad. One is they can physically get bigger over time, and that's not good because it can push on things. And a second is they can leak blood or bleed, and that blood can either irritate the surrounding tissues, causing problems with the way nerves work in the brain or spine. They can cause seizures, headaches, and depending what location they are in the brain or spinal cord, they can have different neurologic effects. This is an MRI picture of a little boy and a picture of the spine. You see this little tiny dot and this is another way of looking at it. It's very small. People weren't sure what it was. He had had a little complaint of some difficulty with his feet. And then several months later, you can see that this dot is much more conspicuous, and this was some bleeding into a cavernous malformation. Luckily, he did very well, but these are the kind of problems that they can cause. So what do we do about them? You know, as folks that are physicians, scientists, researchers, family members, if you know you have a cavernous malformation, what do you do about them to prevent bad things from happening? Well, part of that is the initial question I asked, which is, who do you treat? Because some of these malformations can sit quiet for years, decades, sometimes your whole life, and not do a darn thing. And you certainly don't want a surgeon like me involved or doing anything if you're going to be perfectly healthy without them. On the other hand, a number of them can bleed or cause problems, and you want to get rid of them so that people can enjoy a better quality of life without these things causing difficulties. And that's where you look at what's called the natural history, you know, what happens to these cavernous malformations over time. And we hear a lot of questions about this in the office. So the first question we guess is, well, how do you find out you have one? And when we look at least for children with cavernous malformations, since I'm a pediatric neurosurgeon, the majority of them are found after there's some bleeding into them or they grow. So about 2/3 of the time, people find out they have these because they bleed and they cause some symptoms: headache, seizure, weakness, things I might have mentioned before. About 1/3 of them may present with a seizure specifically, and about 1/4 are found just out of the blue. This may be because there's a family history and they scanned other siblings or parents to look for them, or it may be that little Timmy or little Susie had a fall, they had a bang at the playground, they got a scan for a concussion, and whoops, they found that they had a cavernous malformation. They're roughly equal between men and women in general, and many times they'll have this little vein next to them called a developmental venous anomaly, or DVA. That isn't part of the cavernous malformation, but is draining the blood from the cavernous malformation. This is important because people ask about this later on. People ask, well, Doc, how often are these familial, where they'll be in other members of the family? And how often are they just a one and done? They just happen because one kid had them because one little set of blood vessels went funny, if you will, around birth. Roughly about 10 to 15% of kids will have a family member affected. It'll be genetic. And about 80%, 85% are just spontaneous. They happen out of the blue. And the last thing people ask is, where are they in the brain or spine? Basically, they present roughly where the most tissue is. So about 3/4 are up in the top of the head, called the lobar region, because that's the biggest part of the nervous system. And then the rest of them are fairly evenly distributed between the back of the brain, the cerebellum, the brain stem, and then down in the spinal cord. One thing to note is people who have had radiation before for brain tumors or other problems, radiation seems to be a trigger for causing cavernous malformations. That's another group to think about that aren't just incidentally found. How often do we see new ones? Well, basically, if you have a family history of cavernous malformations, if you have a genetic form, people tend to grow new ones roughly at the rate of about 3% per year. Might be a little higher, might be a little lower. It may be that they were there all along and then they're just they couldn't be seen with MRIs before and they just get big enough to be seen later, or maybe actual new ones that are growing, and this is sort of active areas of research. If you just have a spontaneous one that's not familial, it's very, very low that you grow new ones, less than 1% per year. Now, a really big question that we get a lot in the clinic, I think, is what makes them bleed? If you have one in the head, if you have one in the spine, gee, doc, I'm nervous. Why would these bleed? What can cause them to be a problem? And there's a very nice paper out from California that looked at vascular lesions, including specifically cavernous malformations, and asking what makes them bleed. The take-home message really is trauma, despite what you might think, probably doesn't specifically cause these to bleed. So things like sports, baseball, basketball, getting the occasional head bump, while it's not good in general, as a neurosurgeon I would recommend against it, it probably doesn't increase or decrease the rate of bleeding in any statistically significant way. So we generally encourage people to play sports, although without firm evidence, I would nonetheless probably recommend against things with repetitive head strikes like boxing or contact football. But in general, trauma is probably not a trigger. The other thing people ask about a lot is infection. Hey, doc, I've got a cold. My child has a pneumonia. Again, at least from a really good study, it seems unlikely that infection causes it. The last question people ask about is blood thinning agents, particularly in grown-ups. Do they need to be on blood thinning medicines for other reasons? Do you take aspirin for your heart or something? There's probably not much data that tells you one way or the other. In general, it's probable that high doses of blood thinning medicines are not good, but a simple baby aspirin is probably not an increased risk based on natural history data. So in general, triggering and what makes them bleed is not well known, but most of the normal daily activities should not make anything better or worse. So we encourage a lot of our patients to live normal lives, be active, play sports, do the things that they like to do so that they can be active, healthy members of the community. The other question people ask is if they've had bleeding already or you find them, not what triggers them to bleed, but how often do they bleed? If we are sort of measuring the likelihood of something happening, what do we see? And what we find is that if you're incidentally found, if you're a little boy or girl or an adult that gets a scan and they just find it because you were in a volunteer study, the rate of bleeding per year is pretty low. On published reports, between 0.5% and 1% per year. So that's pretty low. On the other hand, if this has bled already and you see bleeding there, it changes the numbers quite a bit. And the bleeding rate is about 11% per year. And that's actually higher in the first couple of years after you have a bleed, about 18%. So if something's bled already, it's probably a bad actor. It's angry. The blood vessels may be a little irritated or weaker, and they may bleed more in the first couple of years after a hemorrhage. But the longer out you get, or if it's just found incidentally, the likelihood of bleeding, thankfully, is pretty low. What this means is that this really informs, the question for doctors and for patients alike. How do we follow these? What are we supposed to do? And the bottom line is, for most centers, people are fairly aggressive about imaging and scanning in the first few years after a hemorrhage or after treatment. Most folks around the first 3 to 5 years. But then after that, since the bleeding rate drops way down, scans may be spaced out at much wider intervals. People tend to ask and be worried about, scans. Gee, doc, is there a risk to getting pictures? Is there danger, especially in kids? As far as we know, MRIs really do not have any danger to children or adults in and of themselves. Repeated sedations, going to sleep, especially in young children, may have a tiny risk. There were a number of articles a couple of years ago about general anesthesia, particularly in newborns. While there is a tiny risk to anesthesia, that risk goes down as children get older. And since these are scans that are usually every year or so, and they're usually not in newborns, I would say that that risk is pretty low and the benefit of getting the information we need with the scan is high. People also talk about the contrast dye, the gadolinium. Again, while you don't want to do anything to excess and people can have allergic reactions, the danger of gadolinium, especially if it's spaced out over multiple years, is probably very, very low. So the bottom line is we wouldn't worry about scans a whole lot. CAT scans, which have radiation, do have a tiny risk, but again, most pediatric centers where you're most concerned in the developing brain have protocols now to minimize the dose, and it's different than what's given in adults. So while you don't want to do excessive scans, I think the take-home message here is you get them if you need them, and you especially look in the first few years after a hemorrhage or a treatment. The next question people ask a lot are, what about specific locations, doc? I have a cavernous malformation. Is one part of the brain or one part of the nervous system more dangerous than the other? What do we do about them? Are there things that we need to be concerned about? We know what a cavernous malformation is. We know why we're worried. We've talked a little bit about when they bleed and how to manage them. Now they say, well, doc, what about parts of the brain? And how does that relate to surgery? How do we treat them if we need to? So One area that comes up that's relatively rare but important are the basal ganglia. And this is the deep part inside the brain which can affect movement and control of different parts of the body. And people get very worried about this. As I mentioned, it's only about 8 to 10% of all cavernous malformations, but these are places that are tough to reach to, and people ask, well, hey doc, as a surgeon, can you get in there? What happens if you operate on them? And thankfully, you can treat them reasonably well. The area, the basal ganglia, this is a picture of an MRI scan here, and you can see this dot, which is fairly big, deep inside the brain, and you might say, gee, that's kind of tough to get to, but over the years, and I'll talk a little bit, some of the advances that surgeons have made and navigation, we've gotten better at taking these out. And I think the take-home message here is, while you don't want to go to the basal ganglia if you don't have to, if they're small, if they're not causing problems, if they're big, if they're growing, if they're causing symptoms, take it out. If it's bleeding repeatedly every couple of months, every year or two, take it out. On the other hand, if it's small, if it's not bleeding, if it's not causing symptoms, I think the natural history, both for this specific location and also based on the data I showed you before, we'd probably leave those alone and just watch them carefully. So for surgical treatment of this part of the brain, while you can treat it, I think there's very specific indications when it's a good idea and very specific indications when it's good to leave it alone. The other location that people talk about a lot is the supratentorial, which is Dr. Spy talk really, for the rest of the brain. This is by far the most common part of the brain or parts of the brain where cavernous malformations are found. In general, people would operate on these if they were growing, if they were bleeding, and these are also specifically for surgery, parts of the brain that cause seizures. And so, as I mentioned, about a third of patients will have a seizure as their presenting symptom. Ideally, if you can manage this with medicine, or if it's a tiny cavernous malformation, you may leave it alone. But it's important to understand that surgery does really well with treating, not just removing the cavernous malformation, but also stopping seizures. And in our series, along with multiple other series that have been published, we can make kids seizure-free about 96% of the time after surgery. And that is either with or without removing the little ring of blood that sometimes happens around the cavernous malformation. So I think one of the important questions that patients ask with surgery is, hey doc, forget about curing the cavernous malformation, what about my seizures? Generally, surgery is a great option if medicine isn't working to not just get rid of the cavernous malformation, but actually to cure or significantly reduce the seizures. If you look at all the different series that have been published, not just our group, but others, the take-home message is that you can get a full removal, complete resection of these cavernous malformations in the top part of the brain 99% of the time, which is pretty darn good. That's about as good as it gets in any field of medicine. There are complications, but they're very rare, only about 4% of the time. So it's never zero, but pretty close to that. And again, 94% of the time, you can cure or markedly reduce the seizure threshold. So I think that for a long period of history in multiple centers, the idea of seizure control, not just cavernous malformation removal, is a really powerful indication to help with management. We can get people off medications and essentially cure them if they've been selected properly. The take-home message here, like Nike says, just do it. And I don't mean to be cavalier. I certainly don't, as a dad myself, you don't want to be flippant about doing surgery. But I think if there's a clear indication and they match all the criteria, there's great data here to suggest that surgery can really help improve the quality of lives of patients if they're carefully reviewed by the teams that are involved in their care. Now, the final sort of questions people ask a lot of times are, doc, it's great that you have these surgeries already. I appreciate that you can get rid of these cavernous malformations in some cases or improve seizures, but I think the Angioma Alliance and all families and physicians, nurse practitioners, researchers involved in taking care of folks with cavernous malformations, we always want to do better. And I think some of the key questions are, how can we treat better than we're doing already? So this is sort of, a little cartoon here. He's good at thinking outside the box. Most of them prefer to keep him in the box. But I really think that one of the great advances of the Angioma Alliance is pushing forward, advancing the care of patients with cavernous malformations. It's a relatively rare condition, all things considered, and I think one of the great things that is done with this group is to push the envelope and think outside the box in terms of treatments. To start, I do want to talk a little bit about surgical advances, because as a surgeon, it's what interests me, but more importantly, at least currently, this is the sort of standard of care for cavernous malformations that need to be treated. And the most important thing about surgery in the brain and spine, anywhere in the nervous system, is really getting to where you're going, where the cavernous malformation is, and getting there safely. You want to be able to get to the part of the brain that harbors a cavernous malformation without injuring the surrounding brain. So how can we get where we're going better? So the hardest things are getting the difficult locations. And this is, for example, the brainstem, the spinal cord. And one way that we've addressed this is to say, well, first of all, you may not need to operate on some of these. The brainstem, a lot of these cases may, particularly in children, not need surgical treatment, as shown on some of the data earlier. They may not need to be treated at all. They may bleed and sit quietly for a very long time. But if you do need to get there, people have learned ways to get to the brainstem very effectively. This is just one series from a hospital here in the Boston area. Trying to get to this very hard part in the center of the brain, we are able to use navigation, able to make a very small incision on the area near the cavernous malformation. As you can see here, there's this little bit of staining on the side of the brain stem, very tricky area to get to. We're operating in a hole about the size of a dime or a quarter. And with that, we can take out this cavernous malformation, pretty minimally invasively by using the right corridor. Essentially, we're taking natural routes that the brain already provides us and not actually going through the brain itself until the very tail end, but rather following natural clefts and holes in the brain tissue that preserve and protect the brain as much as possible. So this is one advance to getting to tricky areas. Another way is to try to be less invasive overall. This is sort of a real mix of high-tech and simple. Essentially, if you could get exactly where you need to go, this is a picture of the brain here. You can see a cavernous malformation inside the brain. And previously, it would be hard to get to these areas without making a very big opening in the brain to locate where you are and get where you need to go. One way to make the surgery safer and faster is to use either an ultrasound or navigation, where you can have sort of a 3D image of where this is, and then you pass a small guide catheter, something about the size of a grain of rice or a Tic Tac, and this will bring you directly to the lesions. You can have a very small tube or a very small route to this, disrupting as little tissue as possible and safely and quickly getting to the operation. This is an example of, again, using the ultrasound here. There's a little tiny opening. We're able to use this catheter as a guide wire. During the ultrasound, you can see exactly where you're going. You can see this cavernous malformation down inside the brain. And then, although we have an exposure of the brain, we're able to make an opening that's very tiny. This is an example of the catheter itself, bringing us directly to the lesion. We can make a very tiny opening here, again, about the size of a dime or so, even a little bit less. And this allows us to go very speedily right to the brain, unlike, previously we have to go back and forth with the ultrasound or the 3D imaging. And ultimately had this very tiny tract that let us get to the deepest part of the brain, really, with very minimal problems. So this has been a real nice mix of sort of old-fashioned directness with high-tech imaging. One of the other big things, which is newer and still being developed, are lasers. Lasers have been around for a very long time, but lasers for cavernous malformations are kind of a new field. The idea is using laser light to heat tissue, kind of like a sunburn, if you will. And like you can see in this cartoon from one of the companies that makes these, you make a very even smaller incision, and with navigation, you can pass this little laser wire, essentially, to the cavernous malformation itself. And the idea is that by turning a laser on and watching it heat up with a special kind of MRI picture during the procedure, it will essentially not burn, but heat up the cavernous malformation and kill the tissue. The advantage is that it is much less invasive. It's still surgery. You have to make an incision, you have to make a little opening in the bone, and you have to pass in a little catheter. But it is certainly less than most surgeries now, the shorter recovery time in the hospital. And another advantage, it can be done near blood vessels. So some cavernous malformations are near things like a developmental venous anomaly or near other major blood vessels in the brain, where surgery might be difficult to work around those blood vessels. Here, if you can get the catheter there, the blood vessels act like a heat sink and basically remove the heat from the normal blood vessel while allowing the laser to burn the cavernous malformation. Now, as great as all this sounds, and it is really exciting, it is a new technology. Some of the limitations now is they're hard to treat bigger cavernous malformations. The laser is only so big, you can sometimes give multiple little dots of treatment, but essentially most folks would limit this to tinier malformations in harder to reach places, whereas bigger malformations with a lot of blood around them, malformations that are causing a lot of pressure on the brain, probably should still have more conventional surgery, at least until better data is developed. The other thing, because it's a new technology, as exciting as it is, it's hard to know long-term efficacy. There was one study where they were able to go back in after because the seizures were not controlled with the laser, and they did an operation and found that the cavernous malformation appeared to be vanished after the laser treatment. So it may actually remove the tissue in many cases, but we just simply don't have years and years of follow-up like conventional surgery. So I think lasers are a very exciting new field for cavernous malformation treatment. My hope is that they are less invasive, they still have risk, and they are limited to a specific subset of cavernous malformations. But I do think they add to the toolbox that surgeons have to make the lives better and safer for patients with cavernous malformations. How can we apply these surgical advances, whether you're doing lasers, whether you're doing open surgery, whether you're doing ultrasound guidance? Surgery is the key and the mainstay of treatment for cavernous malformations currently. And as a surgeon, one thing you want to be able to do is to perform the activity as safely and as quickly as possible. And so one thing that's being done both at our institution and at other institutions around the country is 3D printing. The idea is that you can take a scan of a patient and in a very short period of time actually build a patient-specific 3D model that exactly emulates the cavernous malformation and the surrounding anatomy. You can look at blood vessels, you can look at bone, you can look at brain tissue, you can get down to 16 micron detail, meaning the width of a cotton fiber. And the advantage of this is that you can do the surgery, you can rehearse the surgery before the actual surgery is done on the patient. So this allows us as surgeons to practice, whether it's placing a laser wire, whether it's approaching the brainstem from a difficult route, whether it's getting a cavernous malformation near significant blood vessels or sensitive parts of the brain. The advantage here is you can get patient-specific 3D models that are printed that allows us to treat the patient more effectively. The way this happens is if we know there's a case that's going to be done, for example, this cavernous malformation located in a tricky area, you can submit a request. Usually within about 12 to 24 hours, they can print out the model. We can review it as surgeons, and then they will print it, and they can print it different ways. They can print it with the brain there, and you can rehearse the surgery with the same instruments in the operating room. You can get life size, you can make it smaller, and you can get to these tricky areas beforehand. So this is another exciting way that we're sort of advancing the field that isn't really conventional, but nonetheless, the bottom line is I think it makes people's lives safer and better, and we've published this and shown that this shortens operating room time and is safe for the patients. Now, I've talked so far really about surgery, and that's been the primary focus of this talk, is that's been the primary treatment for cavernous malformations, but that doesn't mean it should be the only treatment. And I really think that one of the key roles for all the folks involved with cavernous malformations, families, researchers, surgeons, scientists, everyone that's interested in this field, is we need to push the field forward. And one of the goals would be to put me as a surgeon out of business in cavernous malformations. There's been some great new ideas, some that have been around for years, some that are relatively new. And the two big areas are drug therapies and diet. So there are a number of different types of drugs that have been tried either to stop the progression of cavernous malformations, help them to shrivel up, or reduce the rate of bleeding. One of the most exciting ones are Rho kinase inhibitors. These are enzymes that seem to be involved in the development of blood vessels, and there are a number of exciting drugs in the pipeline, some of which are actually in trials or about to start trials shortly. Other medicines have been designed to try to reduce the inflammation around cavernous malformations. Beta blockers are a drug that some groups have done some great work on, potentially abrogating the progression of these diseases, of these malformations. And then part of blood vessels in cavernous malformations that cause problems are their growth. And so this process called angiogenesis, which is growing new blood vessels, may be abnormal in cavernous malformations, and targeting specific proteins that regulate this blood vessel growth may be useful therapeutic targets. One in particular is thrombospondin, and there are drugs now being designed to target this pathway. So there are a lot of drug therapies that are in the pipeline, or some even coming to trial. The other new area, which is, again, a little more questionable, but certainly exciting and some really innovative work, has been in diet. There was a wonderful paper that just came out this past year looking at the microbiome, which is fancy talk for the bacteria and the living things in your gut, and how that process may influence the growth of cavernous malformations. Now, this is a really innovative, amazing study. It does involve a mouse model and a very specific type of multiple cavernous malformation. So I think it's important for families and patients to recognize that this is sort of cutting edge new stuff and may not be directly applicable to immediate treatments. It needs a lot more research, but it is a really interesting look into the mechanisms that may drive what makes these malformations form. So it may be that in addition to the drug therapies to affect the natural history of cavernous malformations that are already there, things like diet, especially if done early or with people at risk, may reduce the formation of new cavernous malformations down the road. So that's what makes this a little bit different. It's also vitamin D3, which is something that may also help to regulate the growth and progression of cavernous malformations. So there's a lot of really cool new ideas and therapies that are out there. I really want to compliment the Angioma Alliance for promoting the research into these innovative areas. I do want to caution families that, it's important to understand what is mainstream and what is developing, and having a conversation with your treating physician, your treating doc, will be important to put everything in context specific to you or your family member. So, we need to make the research go forward, and we also need to make sure that it's vetted and safe before we start applying them across the board. So what are the take-homes here? What are the conclusions, I think, from where we are now and where we hope to go with the treatment of cavernous malformations? Well, I think it's pretty straightforward to say, especially in the audience here, that cavernous malformations are a significant healthcare burden for affected patients and their families. Whether they're causing troubles and need to be treated, or even if they're doing absolutely nothing, the psychological burden of knowing they're there and wondering about how to treat them, how to follow them, it can really affect people. And I hope that some of this information will provide some guidance as to when to treat them, when to be nervous, and frankly, when to relax a little bit when hopefully this is one of the less worrisome ones. Improving outcomes for all patients with cavernous malformations, but especially children, will require advances from multiple disciplines, innovating across traditional lines of study. So this is where you really need to bring together a lot of different people. It can't be just surgeons. It can't be just test tube researchers. It can't be just, neurologists. I think this is a multidisciplinary disease, and it requires multidisciplinary approaches to get new ideas. In terms of right now, I think stratifying risk, figuring out who needs to be treated, who doesn't, through proven population studies, coupled with these developing technologies like biomarkers, like radiographic studies, will help to clarify the best treatment plan for each individual patient. And I think it's really important to make sure that folks understand that every case is different. There is no one size fits all. And it really is important to get discussion with your healthcare provider, hopefully at a place where folks see a lot of cavernous malformations, so you can get an experienced set of eyes working in a multidisciplinary group. The last thing I think is that kids and adults, everybody with cavernous malformations, will really benefit from novel approaches to treatment, including new operative techniques that we talked about, advances in molecular biology, unique methods of visualization and training, such as 3D printing and simulation, and really drawing upon every avenue of expertise, putting everybody under one umbrella like the Angioma Alliance does, to really advance the care for patients with cavernous malformations going forward. So I really appreciate the opportunity to speak with all of you today. I hope this has helped a little bit in providing some information about cavernous malformations, a little bit about the natural history, a little bit about when we operate, when we don't operate, what the operation involves, and then lastly, some of the exciting new treatments that are on the pipeline coming along. So I think with that, I'll stop the lecture and then maybe open up to some questions. So I will switch back here and see what Connie has to say.
Thank you. Thank you, Dr. Smith. That was wonderful and so informative. We did collect a number of questions ahead of time, and I just want to pass some by you, especially the ones that are specific to surgery. Someone asked, is there ever a situation where a CCM resection would be performed where the approach is through the nose?
Right. So in general, you never say never, but it would be highly unlikely you would do a cavernous malformation resection through the nose. That's called a transsphenoidal surgery. In most of the time, the approach through the nose is very limited to specific parts of the brain, the pituitary gland, the undersurface of the eye nerves, and it can be an area that is not typically where cavernous malformations grow. There are isolated case reports. In the right anatomy, it would be the right approach, but by and large, that's not a typical means by which to approach cavernous malformations, simply because they're not in that part of the brain in most patients.
Thank you. Is there ever a situation or a time where it's appropriate to remove multiple lesions in one surgery?
So certainly you can remove multiple lesions in one surgery. I've done it, others have. Most of the time, folks that have multiple lesions, you really want to understand what the purpose of surgery is. Every time you do more operating, you increase risk. So multiple resections are usually predicated on two things. Either one, you have multiple lesions that are growing or causing symptoms, and therefore it's justified to take them out. Or you're taking one out that's causing a problem, and you're so immediately adjacent to another one that it will really not add to the risk of removing it. So for those two reasons, you would probably remove multiple lesions at once. On the other hand, just taking them out because they're there is probably not going to benefit the patient, especially if they have numerous malformations, and you really want to limit your surgical intervention to targeting the ones that are causing problems, because it's likely you may be doing other surgeries down the road. The more surgery you do, the more scarring there is, and the harder subsequent surgeries are.
Thank you. So this is kind of a twofold question. One is, with seizure in a child that has, or an adult that has multiple lesions, how do you go about deciding which of the lesions to remove? And then the second part of that is, if the seizure isn't resolved, seizure disorder isn't resolved by surgery, and the hemosiderin has not been removed as part of the original surgery, do you ever go back in and take additional brain tissue out?
So this is a great question, and one that comes up a lot. As I mentioned, about a third of patients show up with seizures as they're presenting problems. This is a very common issue. If you have a single lesion, one of the things that you want to do, and this is where I really would stress, you want to go to a center that has a multidisciplinary core that treats cavernous malformations and has an epilepsy or seizure team. And with this, part of the evaluation before any proposed treatment like surgery would be to have the epilepsy team evaluate the patient, probably do an EEG. They can sometimes do something called magnetic encephalography. I can't pronounce it, but fancy magnetic studies. But the point is they can localize where the seizure is coming from, and then they can look at the anatomy and see is where does the seizure start, and does that match with where the lesion is. It may be that the two coincide, and then you can figure out which cavernous malformation is the bad person that you need to remove. Alternatively, there are certainly situations where people can have seizure for other reasons or have what's called multifocal epilepsy, where there are multiple spots that cause seizures, and taking out one cavernous malformation may not have anything to do with the seizures or may reduce some of the seizure threshold, but not all of it. So really getting a full epilepsy evaluation with targeting seizure focus coupled with anatomy is the first step to answering that question. The second question, what happens if you've had a cavernous malformation you thought was the bad guy, was causing the seizures, you remove the cavernous malformation, do you ever go back? Do you ever have to do more? So as mentioned, if you're carefully selected beforehand, you have a high 90% chance of curing or markedly reducing the seizures right from the go. But that leaves 5–10% of people that are still going to have problems after. And in those cases, there may be a need to go back for further surgery. The two issues that you want to address in that case are, one, again, is the seizure actually being caused by the location where the cavernous malformation used to be? Sometimes people have seizures in other areas, and if they've been masked or difficult to find, you want to know that, because if you're operating on the left side and the seizures coming from the right, taking out more hemosiderin will not help things. So first thing is to be sure that where you had the surgery is still the problem spot. The second thing is removing additional tissue, if that's the seizure focus, many times can help reduce or remove seizures, again, about 2/3, 80% of the time. It really, one of the key things to think about, though, is that in some cases, the reason some tissue is left behind is it might be in a very high-risk area of the brain. So if it's in a motor area, if it's in a deep part of the brain, people may say, you know what, it might cause really undesirable side effects to go back in a second time, and that may be where you have to think about medication therapy. You may have to think about, an awake operation where you can monitor the child or the person awake, or you may say, we're going to do the surgery, but it's higher risk. So bottom line, going back in can help, but only if you've carefully selected them and you've had a good talk about, what the risks and benefits are.
Okay. And one final question. It was about going in and finding that only a partial resection is possible. Do you think that doing a partial resection is enough to reduce the risk of rehemorrhage?
So that's a great question. Suppose you have something where you can go in and you can't get it all out. Now, thankfully, that is the vast minority of cases. Almost always, just due to the nature of cavernous malformations, you usually can get them all out or get the vast majority out. Clearly, if you get out 90+% of a cavernous malformation, you're going to markedly reduce the danger of a physical mass pushing on the brain. You're going to markedly reduce the risk of severe hemorrhages that might cause life-threatening problems. One thing that's important to distinguish is a little bit of bleeding, if it's tiny or a small amount, probably is a lot safer than a lot of bleeding. So it may be that the surgeon speaks to the patient beforehand and says, I'll get out 80 or 90%, but if it's stuck to an important blood vessel, if it's in a deep part of the brain, I may deliberately leave a little bit behind, but by reducing the so-called mass effect, the pressure on the brain, the nerves around there may work better because they've got better blood supply, they're not squished. And while there still may be a risk of bleeding or growth in the future, the just general size of the overall problem is so much smaller that the quality of life is improved. So while the bleeding amount will be less, the bleeding rate may be the same. It's just that it's so much smaller that life is better. It may also be that by cutting out the blood supply and making the cavernous malformation so tiny, it may actually bleed less as well. I think the literature is very, very spotty on this, but my personal experience has been that generally it helps. It's just a matter of being clear what the expectations are with the family.
Wonderful. Thank you. Dr. Smith, thank you so much for joining us today, and I look forward to having you again some other time, and as things progress and there's more information to share with our families. So
well, it's been a real pleasure, and I really, again, I want to compliment all the work that's been done by you, by your group, and by all the members, both families and physicians and researchers alike. It's very inspiring, and I think we've done an awful lot. I think there's a lot more to be done, and I look forward to hearing what the group does next.
Great. Thank you.